So that was my first point. Okay, welcome everyone this afternoon to the AGM for Kingston CCG. So matters are like sort of just a few housekeeping details. So as our colleague over there just kindly reminded me, if you can just switch your mobiles to silent or switch them off for this afternoon, please. Also, the other thing is that the fire exits are labelled out there and straight out the back from behind us. I am going to try and keep us to time if possible, so I'll just excuse me for cutting people short on occasion, but we will try and run to time. The other thing is just to let you know that this is being live streamed, so it's going to be put on our website, and this is so that we continue to be open and transparent, particularly around communications and also record keeping as well. So, and also with regards to the Q&A session, the filming will be on the panel, but obviously the questions and the answers will actually be up on the website itself as we proceed. So, what I'd like to do first of all is just introduce the panel, introduce myself, and then we'll take you through the agenda for the afternoon. So, I'm Naz Giovanni, I'm a GP in New Malden, but also chair of Kingston CCG. And on my right?
I'm Sarah Blow. I'm the accountable officer for the CCG. I'm also the accountable officer across the South West London Alliance of CCGs.
Thank you. Oh, let's try this one. Hi, I'm Yarlini Roberts. I'm Director of Finance at Kingston and Richmond CCGs.
Good afternoon, I'm Tony Michaelides. I'm the Managing Director for Kingston and Richmond CCGs.
Okay, thank you. So what I'm going to do, I'm just going to give you a brief background of the Kingston population, and then we'll hand over to Yarlini to go through the finances and annual accounts. So if we come to Kingston CCG, we are made up of 21 GP practices in the community. We service just over 205,000 of registered population, but we actually have around about 180,000 patients resident within Kingston. That means that we do have some people who are registered with GPs that actually live outside the borough of Kingston. About a third of them are from BMA background, and our budget as Kingston CCG is around about 255 million. So looking at the, there you go. So looking at the life expectancy for Kingston residents, it is above national average. I think national average is around about 79 for men and 83 for women. We do have a healthy population, but it doesn't mean to say that there aren't needs within our population. We do have areas of deprivation where the life expectancy is lower, and this is one of our main aims, is to try and make sure that we have equality of services within these areas. We do have an ageing population. Now, as definition, ageing population just basically means that there is a higher proportion of people who are older within our population in Kingston. And because of that, the needs, the health needs and social care needs of that population does change with time. I think the national view on the age whereby you start needing health services is around about the age of 63, and most people live healthily up until about the age of 63 and then slowly start to access services. So if you look at our life expectancy of 81 and 84.9 for men and women, that means you're talking about quite a significant proportion of their life where they will probably need access to services. And also, we are seeing a growth in the number of children and young people who live and study within the borough of Kingston. So what I'll do, I'll hand over now to Yarlini, who'll go through the finances and the annual accounts. I'm quite happy to take questions as we go along, and then we'll have a good Q&A session at the end for anything else. Okay? You're going to go over there, aren't you?
I'm going to try and do that.
There you go, right and left.
Not sure if it will work. Oh, it does. So hi, you know that I'm Yarlini, and I've been at Kingston for a long time, and I recognise quite a few of you, so it's very nice to see you all again. So I'm here today to present the 2017-18 annual accounts, and I'm really pleased to report that actually, despite a really challenging year, Kingston CCG has managed to meet all its financial targets. So we've done really well at maintaining our financial stability and not exceeding our budget. We've used our resources wisely, and we've received an unqualified opinion from the auditors in terms of value for money. We've managed to stay within the statutory running cost allocation, and in fact we've come in slightly under. And we put in our report and we submitted that on time, and we received an unqualified audit opinion. So actually, we've done jolly well. So if I give you, I think I've gone a bit too. Where's my? I knew this would not work. What I was? Oh, I've lost my pie chart. I've lost my pie chart. I will, and do you know what? That's so difficult because actually, that was the only colourful thing on my presentation. So I will talk to you about it. My pie chart was about how do we spend our money. So you'd have heard from NAS that actually through the Department of Health we get an allocation of 255 million. And how have we spent that? So actually you would have seen, and I think actually it's in the summary, we spend just over half of that on the acute services. We spend about 8% on our community services and about 12% on our primary care. So a lot of patient focus there. And we also look at, obviously we contribute towards the Better Care Fund and work with our social care colleagues at trying to get that wraparound service for all of our patients. Right. For running costs then, the running costs is a mandatory target that we've had to do. You'd have heard it all in the press about trying to minimise the costs that we have to running the organisation. Our allocation that we had this year was just over 4.2 million, and actually we came in slightly under. So that means that we spend £21.90 per head of population for Kingston residents on administration costs for the CCG. And that also includes things like the estate costs that we have. In terms of the summary and moving forward, it's excellent that we've managed to meet all cost pressures, maintain our performance and put the patient first in 2017-18. We recognise that, as is everywhere else, 18-19 is an enormously challenging time that we have. However, that being said, we've submitted our financial plans for 18-19 to NHS England. These have been approved. We've met the required surplus of 0.4%. We've identified all the necessary savings that we need to make to achieve that. And we're working with all our stakeholders to try and ensure a financial stability moving forward. What we have been really good at doing is being really robust in terms of our financial governance, and actually maintaining this and moving forward on this will be absolutely crucial in future years. So I'm happy to take questions now or later when we're doing our panel.
So are there any questions for Yarlini around the finance and the accounts? No, very clear. Thank you. Okay, so I think what I'll do now is just give you a brief overview of the performance that we've had over the past, over 17 and 18. And does this work? Okay, so our regulator, NHS England, actually assesses Kingston CCG on a series of metrics, and it's all part of the improvement and assessment framework. Now, as part of that, there are 5 areas that they assess us on. The first is cancer, maternity, then mental health, dementia and diabetes. Overall, we were assessed as good, and we were assessed as outstanding within cancer and maternity, good within mental health, and requires improvement in dementia and diabetes, and we'll come to that in a minute. There are several metrics underneath these titles, so I'm very happy to explain those to you if you wish to, but there are some details behind this as to how they assess us as either outstanding or requires improvement. So going forward, there are other targets that we as a CCG look at across the board. And for example, one of the targets is around cancer, and there are lots of different cancer metrics that we look at. All the targets were met except for the 60-day first day treatment target referred through a screening service, and also the 31-day subsequent treatment target for radiotherapy. The referral to treatment target was met, and also the diagnostic target. So these are the waiting times for your operations and waiting times to actually get investigations. So those were both met. The A&E target, obviously, I'm pretty sure that you're aware that A&E has been a real significant, has had a real significant difficulty right across the whole of England to try and meet the 95% target. So the 95% target is looking at how many patients you see and are able to treat and either discharge or admit within a 4-hour window. Kingston Hospital has achieved just over 90% compared to the target, which is meant to be 95%. We'll come to that in a minute as well. As regards improving access to psychological therapies, the access and recovery targets were achieved in Q4. And the IAPT waiting time targets were met for the whole of last year, which I think is a really good reflection of some very, very good work from the services themselves. The Friends and Family Test surveys show excellent outcomes reported for inpatient, outpatient, A&E, community care, and also maternity services. So when we look for key areas of improvement, one of them, as I said before, is around the A&E delivery target. And so we're working on a health and care system within the bounds of a delivery board called the A&E Delivery Board to try and look at scopes right across health and care provision to be able to help with the A&E target. So there's been an awful lot of good work in amongst different provider services, in amongst commissioners as well, to actually try and drive up some of the targets within A&E. And we're hoping that what we've put in place will be built on and will actually improve the target going forward. The proportion of people diagnosed with dementia, on the previous slide, 2 slides ago, you saw that dementia was one of the ones that required improvement. And this is mainly around the diagnosis of dementia. And we've done a lot of work. We've had clinicians going into homes trying to identify people with dementia. And the reasons for doing that is that we can then provide services to be able to help with residents with dementia. So going forward, what we've done is that we've seconded a dementia nurse specialist from South West London and St George's Mental Health Trust to help support practices in identifying those residents. The reason, and as I said, the reason for identifying those residents is that so we can then provide the supportive services for them. Around mental health, we've been talking to the Mental Health Trust about residents with long-term health conditions and their access to psychological therapies, particularly those ones from BME populations and the elder population as well. So that's all in line with best practice. And as regards diabetes, again, on the first slide I showed you, it did say diabetes requires improvement, and most of it is around the newly diagnosed diabetics and then being able to get access to educational services within the first year. So there is a program of work which is being done across primary care whereby new diabetics are referred into the educational services quite often for reasons we're not quite clear about, is that the residents don't tend to attend those services. So there's a lot of work going on behind that to try and improve it. So I think going forward, right, I'll just pass it on to Sarah, who'll give a summary of the achievements for the last year. Do you want that one, this one? That one. Just in case. Okay. Do you want that as well? I want that too.
So good afternoon, I'm Sarah Blow, as I said, I'm the Accountable Officer for Kingston, and I'm just going to talk to you a little bit about some of the achievements from this year. So 2 areas there, primary care and social prescribing. So you may be aware that we now have hubs across Kingston providing support to people who might need services from their GP but not in the normal working hours. So all practices now have 8 to 8 access across Kingston, which means they can access their general practice via a hub with their notes and with all the information about them. So that's a really positive thing. I don't know if you know this, but I think the NHS was single-handedly supporting the international fax machine market up until recently, when we decided that actually that probably wasn't a good way of transferring information between services. So we have actually recently done a switch off of the kind of paper processes that we do between general practice and hospitals, and that's gone very successfully in this area. So we're very happy that we're now sort of doing paperless referrals between general practice and the hospitals. Social prescribing, you will have seen if you were here earlier that there is a stall here talking about Connected Kingston, which is a group of voluntary sector, local community services, local authorities working together to provide a route for people that may not need to be seen by their GP but do need some kind of advice or support differently in the community. So GPs can now prescribe people to go into Connected Kingston and receive different kinds of services than would usually be delivered just by the NHS. And I believe that Connected Kingston launched formally last week or the week before in last
week, and then goes live
Monday, and that all practices in Kingston will have access to that. So that's really, really positive. Changes to prescriptions. We engaged and consulted last year on changing the way we prescribe, and we did actually report back to the governing body on how that work is going, and that included things like prescription for gluten-free and baby milk. Actually, what they've done with this nationally is they've nationally consulted now on what we should be prescribing and not prescribing in general practice, and that is going live and supports very much the work that was already done in Kingston. Children and young people's mental health. We actually reviewed the improvement plan for young people with mental health earlier this year, and it was guided by the views of local children and young people, and they've identified a number of areas where we need to focus, and I think it's looking forward positively for the next couple of years, particularly on things like face-to-face counselling, ensuring that people have a shortened waiting time when they are referred for services, and making sure that we actually have the right pathways, particularly for young people with ADHD or autistic spectrum disorder, and making sure that we can support them in the most appropriate ways. Adult mental health, I wanted to just pick a couple of things out of here. One is the single point of access, which means that all mental health referrals in Kingston go through in a coordinated way into services, which is really helpful for those receiving care. And the other one that I really wanted to pick up on, and I know that Naz mentioned that we are really focused on things like the 4-hour target in A&E and making sure that that is achieved. Well, often we will have mental health patients in crisis in A&E, which is not the most appropriate place for them, and is very difficult for the clinicians within A&E to deal with. Well, we now have in Kingston the Retreat Crisis House, which can support people that maybe would otherwise have been sectioned or gone to A&E. And there's a quote on here at the bottom, which I'm sure you can read, from the local police about what a fantastic service that is, because they now have somewhere that people can be taken to when they're in crisis, and they can be supported in a way that they weren't in the past, where they were sort of going into the wrong services. So actually Naz should be talking about this, because Naz is our lead for musculoskeletal services across South West London, our clinical lead. But what we have done is we've looked at how people access musculoskeletal services, and what we're trying to do is ensure that no matter where you live, you get the same level of service, and that you are given, you know, the right pain relief, the right type of triage, the right type of physio support, or whatever you need before you actually go in to have an operation if you need one. outcomes. So we've put in a single point of triage for musculoskeletal services, and multidisciplinary teams and specialist practitioners will have a look at you, make sure that you're getting the right service before you're kind of pushed between services that may not be the most appropriate for you. And we're also making sure that access is fast and that when you start treatment, you start that very quickly. So I think that's a really positive move as well. I'll just talk a little bit about South West London because we are part of an alliance and we do things at a very local level, but we also do some work across South West London. We actually refreshed our strategic plan for South West London last year. And actually that's on our website, so if anyone is interested you can go along and have a look at that. And the focus was very much in our refresh around the partnership, how we work at a local level and ensuring actually we keep people well and focus on prevention, but particularly how we might develop local health and care plans at a borough level. And I know that Tonya later on today will be talking to you about the Kingston local health and care plan and how we're working to get that delivered and published by the end of this financial year. What we've also done is we've set up some governance, so we now meet together across South West London to make some decisions where it makes sense for us to do so. So we have something called a committee in common. So one of the decisions that we made together was that we were given a significant amount of money to support the transformation of primary care across South West London. And what we did was we met together to decide how we actually spread that money out into South West London, and we agreed a standardised approach across South West London. So no matter where you live in South West London now, the same amount of transformation money comes per head of population. And that means that just under £1 million came into Kingston for transforming primary care. Also with things like cancer care, where you actually see multiple organisations, and particularly if you require some specialist support, you might not stay within one hospital or one service. We've been working together to make sure those pathways work together for the benefit of patients, so that actually if you need to be seen within a tight timescale, which often you do if you've had a cancer diagnosis, we make sure that those pathways for patients are really smooth, and we work across the system to make sure that that happens. And another area that we worked on last year and we intend to work on coming up into this winter as well is around our communications campaigns around how we support people to stay well over the winter period. And actually we'd like to do more of that because we recognise that often in the winter period people need a lot more advice about how they can access support or what they should do if they've got some minor ailment that they wish to treat themselves or through a pharmacist or another route. So future plans, we are still working to integrate our ways of working with our local authorities and with our other partners, and that will also be part of the local health and care plans. Mental health is a big priority for us across South West London, but particularly children and young people with mental health, which we've identified as a priority, and we are going to be bidding for national funding as part of the Green Paper around children and young people mental health. We want to look at outpatient services because sometimes those are a bit outdated. We want to make sure we can support people to be seen as close to their home as possible. So we're looking at how we might redesign those services so that we can support people better at a local level. We talked about transforming primary care. It's not just about access, it's also about how general practice works with other services, including hospital services, community services, mental health services, and we want to work together to support that. And also, you know, Richmond is part of a wider NHS, and we want to make sure that we get the absolute best benefit of working wider for local populations. So we will continue to do that work. And it says a focus on clinical quality. I think it is a focus on clinical quality and clinical leadership across the whole of South West London. I think it's really important that our clinicians are forefront in us delivering our services, but also on ensuring that the services that we do deliver are of a high quality for those that receive them. So I'm going to stop there and I'm going to hand over to my colleague here, Vicky, who is from the designated, I'm supposed to say it here, the designated nurse for looked after children. That's correct, isn't it? Are you okay with your clicker?
So before we start, was there anything specific around Sarah's presentation that people wanted to just touch upon or just get a little bit more clarification on, particularly about what we've had in the past and what our plans are for the future? No? Okay. Thank you, Vicky.
Thank you. Can everybody hear me okay? It's really good to be here this afternoon. I work across Kingston and Richmond CCGs and work very closely with Achieving for Children. And my role essentially is around ensuring that the health needs of our looked after children are met, and think about ways that we can reduce inequality and make improvements and ultimately improve outcomes for this group. Today we have planned for a young person to join me to deliver the presentation. Unfortunately, she couldn't be here. The reason being, after a period of not being in employment, education or training, she's now enrolled in college, and obviously that's where she needs to be today. So you've got me, I'm afraid. What we wanted to talk about was the Children in Care Council and what that is and why it's there. As a group, looked after children have quite specific health needs. They're a group who, over their life course, will experience poor health. Approximately half will have a diagnosed mental health disorder, and 2/3 will have a special educational need, which is, a tremendous impact, not only during childhood, but throughout their adult life as well. We recently had a change in legislation where our responsibilities as a corporate parent mean that we now have to be responsible to ensure the health needs are met until the age of 25. So we're starting to look at that and how we can make that happen. We need to understand our population. So we worked very closely with the Children in Care Council to run a project that they initiated because they wanted to support their peer group and deliver some interventions. So what we decided to do was run a project supported by the Royal Society of Public Health, and we've offered a level 2 qualification, and the 4 modules have now been completed. We're in the marking stage, so young people will come out with a qualification, but also the skills to be able to support their peer group and signpost them to appropriate services to meet their health needs. This is very okay. As part of that, they had to create a medium to communicate their message to the community, and they chose to make some artwork which they entitled Together and Apart. So they're on the table at the back there if anybody did want to see them, but essentially the artwork on your right really was representative of a young person who might be experiencing some sort of mental health crisis. The picture on the left was really about when things were going well. And I think it's really important that although this group may have a high level of diagnosed mental health disorders, they can be well and live with that diagnosis and manage it. So part of the project was looking at self-care and really empowering young people to be able to manage their health. We've got a short film which Tara is going to play. Okay, so we're hoping that our young people will take this project and present it at the Pan London Children in Care Council meeting, and just hopefully give the message that, you know, there's a lot that can be done in terms of self-care, and empower young people to be involved in making decisions around their care with their health providers. So I think the take-home message from this really is, although we've got a group of young people who are often entering adulthood with quite poor mental health, with the right support, you know, they can live you know, productive and fulfilled lives. So that's everything from me. Over to Tonya.
That's great. Thank you. Thank you so much, Vicky. So it's a massively important piece of work, and we look forward to hearing how things are progressing going forward, if that's okay. Thank you. Any questions? Any questions for Vicky at all? No. Okay, we're whizzing through this. All right. Tonya, would you like to come and give us an update around the health and care plan for Kingston, please?
Good afternoon, everyone. It's great to see so many familiar faces and some new faces, so welcome to Kingston. As Sarah said, I'm going to talk a little bit very briefly about Kingston's health and care plan. And the health and care plan really starts to describe how we're going to deliver change for the people in Kingston over the next 2 years. So the health and care plan for Kingston will focus on where we're working together with partners across health, social care and the voluntary sector will have the maximum impact for local people. We're going to publish it in March 2019, so there's plenty of time for people to be engaged and involved in the shaping of the plan. And it will be a 2-year plan for 2019-20 and 2021. So it will describe our priorities for the next 2 years and the initiatives and the action we want to take in those 2 years to make the health and care offer to our population the best we possibly can. It will be informed by the Joint Strategic Needs Assessment, or JSNA as it's known locally, around and health and wellbeing board priorities and current plans and programmes of work. I think it's really important to stress in Kingston, we've been working in partnership for a number of years to deliver the transformation that our population and we know we need to make. We are starting to make some really good inroads, and I hope you would have heard, if you come to some of our meetings, some of the work we're doing around, particularly around managing people with complex health and care needs. But the health and care plan will then set out our ambition for the next 2 years and how we can really accelerate that transformation work. But it's really important to know it's also informed by what the public has been saying to us about what their expectations and needs are from health and care. And we're looking after the last 2 years of insight work we've done across Kingston and South West London, but also look at opportunities for doing some more engagement around particular areas that we haven't focused on to date. And one of the areas I would like to do a little bit more work on is end of life. We haven't really engaged fully with our population around end of life. As I say, it's a partnership work, and the partners are involved in seeking to agree a few priority ambitions and actions in the areas of start well, live well, age well. Those of you who have read our refreshed strategy for South West London, you will recognise start well, live well, age well. Joe, my colleague Joe, is running a stall at the moment in the corner here that gives some details around the priorities. Please, if you've got opportunity after we've finished talking, to go and speak to Joe and look at the emerging priorities, and feedback is always welcome. The plan will be jointly owned by the local NHS, Kingston Council, Health Watch and the local voluntary sector. So it really truly is a partnership plan. And the plan will be overseen by Kingston's Health and Wellbeing Board. Again, we're talking this week, there's a Health and Wellbeing Board meeting, and it's on that agenda there. So opportunities in public there to talk about our plan. Just to give you the milestones of publications of the plan, we're probably at the second circle, case for improvement and priority setting with stakeholders. The activity runs from September now till November. So I say plenty of opportunity and time to be engaged with that piece of work. So let Joe or any of any of my team around if you want to be engaged and you're not involved yet. If you leave your contact details, we can be in contact and make sure you're plugged into the work. But as I say, if you get a chance, have a look at the stall over there. And I look forward to sharing our published plan in March with partners. Thank you.
Great, thank you, Tonya. Are there any questions? Obviously, there's no detail here. This is about the process that we're following to try and help make sure that we've got the health and care plan published by March. As Tonya said, the details are over on your right-hand side. I'd like to bring two things to the forefront, just to make it a little bit more real about what we're trying to do. So the first is around, I'm pretty sure an awful lot of you have heard about KCC, which is Kingston Coordinated Care. Now this is a way of getting colleagues from the health and care sectors and mental health sectors together to actually look at ways of being able to support a person within the community. And this is to try and do several things. First is actually give them confidence in self-management processes. The second is actually know when they need to escalate, to professionals that their needs are starting to become a little bit more serious. And thirdly is to try and keep them well in the community and actually keep them supported within the community, but obviously use our hospital and secondary care colleagues to try and help support them again in the community, and also, if they do need acute care, to support them well in the acute sector to then be discharged back to the community in a timely fashion. So I think it's a really important piece of work. It's something which is continually evolving and developing. It was actually developed right from the ground upwards, so taking into consideration the staff comments and also patients and public comments. And this is how the KCC program was built. So that's one bit of the area that I just wanted to make it a little bit more real for people. The other moving forward are things like the outpatient transformation program, or and again, I see this in a different way. I see it in a way of being able to help support that person in the community and require secondary care input when they require it. So, so with the outpatient transformation program going forward, we're actually working very closely with our hospital colleagues, our community colleagues, to look at ways of being able to get the advice, get the information, and get the support that's required for our patients in the community. So, for example, if patients come to us, we're not quite sure as primary care or as general practice what to do with this patient, we have access now to electronic advice through our consultant colleagues, and we're going to slowly start to build upon that so that the only people that require to go into secondary care are people who require real specialist intervention. I'll give you a very quick example before I start opening up the floor to questions. So a very quick example is that within something like orthopedics, there is what we call a conversion rate. So conversion rate is the number of people you see in your outpatient clinic that will then be converted into surgery. So generally, it's meant to be around about 80%. That's a good conversion rate. Gives you 20% leeway for the more complex patients that you need to get the specialist advice on. But in our area, our conversion rate is really quite low. It's about 25%. So that means the consultant time is being spent on patients that they're never going to operate on. So what we're trying to do is trying to utilize their specialist time in specific areas, so that they're not having to put their efforts into areas where actually they don't need to put their advice into. So we're working with our consultant colleagues on this, and also with the trust, the medical director, the community colleagues, and general practice, as to find out how is the best way of trying to redesign this. And I think I don't like the term outpatients, all right, because I think it's a very outdated term. I think what we need to do is look at supporting patients and public in the community and getting the specialist advice that's required. And I don't like the term referral either. I think it's advice. I think it's getting the information to be able to again support those patients out in the community. So those are two bits, the KCC and the outpatient transformation, that I just wanted to just highlight to you, just to bring it into real terms as to what we're doing. So I'd like to open up the floor to questions. It could be on the presentations that you've already seen. It could be on anything outside or anything that's actually pertinent to yourselves. So anything to do with the finances, our performance, our view, our forward-looking view, our health and care plans. So the floor's yours. So any comments or questions from members here? Yes.
Hello.
We've got one coming up.
Hello, I'm Cathy Warwick. I'm a non-executive director at Kingston. That was all really interesting. Thank you very much. I've got two questions. They're slightly different. The first is, there's been a lot of talk recently about, what the new Secretary of State for Health is saying and what Simon Stevens at NHS England is saying about the new tranche of money we hope is around. And I'd be interested in the panel's comments on how much that was going to support Kingston CCG and the local health economy. And the second question, which is slightly different, is I love what you're saying about transforming outpatients and changing the description and changing the conversion rate. I just wondered how much work needed to go on with the local population to change their view of where they receive health services. So I'd be very interested in comments on those two questions. Thank you.
Yeah, so if I can just pass on to Sarah for the first
So first of all, congratulations to Kingston Hospital on your outstanding CQC outcome. So well done to everyone at Kingston for that. So I think we actually congratulated you at our last governing body as well. But well done, guys. So I think that on the new health secretary, he has a specific priority around digital, which you will be aware of, I'm sure. And digital is something that we're focusing on across South West London with our providers to make sure that we have the most up-to-date processes around how we support the population, but also how we deal with our data and information, and making sure that that's not just sort of shared, but also secure and safe, and doing that in the right way. So that's one of his main priorities. On the money, I think it's very interesting. So there was an agreement, wasn't there, that we were going to get an increase. However, our expectation is that a lot of that will be identified for specific pieces of work. So we know that some of it will be associated with pay rises that we will need to give to staff, so that will take up a significant chunk, I should think, of that money. And secondly, we know there will be priorities coming out, such as digital, such as children, young people, mental health, as part of the Green Paper, where additional funding will go in. So I do not expect it to support existing financial baselines, but what I would do is expect that money to be put into services that are new for our local populations and that will help us to achieve better outcomes. We will be waiting with anticipation, I think, two things. One is the new 10-year forward view, which is being led by NHS England and NHS Improvement. So we're expecting that in around about October, November. And the priorities within that we already know, because they've been set out nationally, and they are things like primary care, mental health, digital. There are a number of areas, 10 or 11 areas, I think, within that. I'm sure that I could reel them all off if I was really pushed, but I don't think you're going to. And then following that, we will then have planning guidance, which we do tend to get, and if anybody that works in the NHS will know, it's usually our early Christmas present, usually on the 24th of December, around about 5 o'clock. We will get our planning guidance for the following year. So we're expecting the 10-year forward view to give us some of the priorities, and then I expect the planning guidance to come with the detail around the money that will then say, and this is what you will do with your money, which will be linked directly, I am sure, to those priorities in the 10-year forward view.
And just coming on to your second part around the involvement of patients public, and also the terminology, I think, from patients, what they expect out of it, and also from the clinicians, what terminology they use. I think that moving forward, that there is going to be a whole engagement piece, educational piece around the way that the whole system is going to be starting to work. I think that within the outpatient transformation program, there are specific programs where patients and public are involved in the care pathways. And it's so, for example, we've done a whole load of audit around the outpatient bit as regards whether the clinicians thought it was appropriate to come back or whether the patients thought it was appropriate to come back, and did a whole audit piece around that to get their views as to what they felt was important. Now, what we have to start thinking about are using existing technologies, and also starting to think about, you know, future technologies that are going to be available to be able to get that specialist advice. So at the moment, emails, electronic advice lines, we're looking at Skypes face-to-face. So there are a whole variety of different ways of being able to get advice from a specialist. And I think it's not helpful to use things like, to use terminology like referral, because as soon as you use that terminology, the patients and the public, from the people I've talked to, always expect to be able to go to a hospital and see a consultant. That's what a referral means to them. So I think there's a whole communications piece and education piece that we will need to do around this. And we need to make sure that hand in hand we're going along this journey, okay, so that the clinicians are using the right terminology and the patients are also using the right terminology and actually understand the terminology moving forward. So I hope that answers your question. Okay. Yes, do you want to introduce yourself and then...
Thanks. Liz Milrabo, Chair of Kingston Health Watch. I just wanted to pick up on the greater use of digital technology, because I've certainly been in discussions in this room where, for example, the electronic patient record and so on, there is a palpable anxiety in certain sections of the population, mainly older people, about the use of electronic means of communication, people who don't have a younger member of the family to help them with it. And I must admit, you know, I've reached the stage of life where I believe in cultivating younger family members, because you don't know when you might need them. And of course, it will often be older people, also disadvantaged people, who have the long-term conditions, who have the multiple problems. So I think that the greater use of IT is great, but can we please also ensure that we're taking the views of people who don't feel confident with these methods of communication, and that it doesn't create anxieties for them?
So can I just so I think number one, absolutely, because I think that this is not about, I think the NHS moving into the next century around the digital work stream is not about trying to stop people from being able to access face-to-face services when they need to, and having that very personal relationship with their clinicians. But I think there are a number of streams to the digital piece. One is around how we work within the NHS. It's how do we make sure that we can see information because it's really interesting, isn't it? Because the population generally think when they go into hospital, they think that the hospital staff can see their medical information. That's generally the feedback I get, and I've been very surprised that they can't. So it's about the services being able to access information that is the right information, the relevant information about that individual, so that they can give them the best possible care. And that's one part of it, and that's what we would refer to, I think, as the electronic patient record. Then there's a whole work stream on things like how do the population access healthcare. So that's things like apps on your phone, and how do you get advice in a different way. And we recognise that not everybody will want to access healthcare in that way, but there are parts of our population that would be really keen to do that and would like to have different ways of accessing support, information, and healthcare generally. So I think it is about us trying to meet all of those needs. So the digital, and the other thing is that we also have some quite outdated systems within the NHS, and it's about making sure that the systems we have are very up to date and actually are supportive to the clinicians working in those systems. So there are a number of streams that are associated with what we call digital, and only one part of that is about how the public accesses services, but much of it is about making sure that we're up to date in our own systems and that they work in a way that makes sense for the clinicians that work within the system.
Yeah. I'd agree. The other thing is around the patients. The digital bit is not to replace. The digital bit is to try and help enhance the services. So when we have to make sure that we've got a whole portfolio of ways of being able to access different services, and it's not to throw a whole load out and replace them with a whole load of digital. So completely agree, and I would be surprised if we ever moved in that kind of direction. Okay, sir, you wanted to ask a question. Do you want to just explain who you are?
Nigel Spalding, also Healthwatch Kingston. Another question on finances. It's good to hear that Kingston CCG has been able to work within its budget and met all the requirements. How are the other CCGs in South West London and also the acute trusts placed financially? And are there any potential impacts on Kingston for what's happening elsewhere in South West London?
So we have a differential position across South West London, is what I would say, particularly in our acute hospital trusts. We have some significant issues around affordability. I would say particularly, say at St George's, I think everyone is aware that they have a significant financial problem. In Croydon as well, they have a significant financial problem. We have some of our CCGs that are struggling financially, including Richmond and Sutton, who both were in deficit last year. So we do have a difficult financial position across South West London, I would say, when you look at it as a whole. And that impacts to some extent on all of our services, because we need to be financially sustainable as an NHS. And we are working to ensure that we do that, and we're working with our providers and we're working with our partners to try and ensure that we get to a sustainable position for all of our services. Obviously, we'd all like some more money, and we hope that that will come and that will help the position. There's no, from a commissioner perspective, there's no plan to move money between systems, so therefore the allocated money for each system will be retained within those systems. What we are trying to do is negotiate with our regulators so that if we have systems that end the year in a better financial position than others, that we then will balance them off. We won't actually move money around, but the regulators will accept that overall South West London balances. So that's what we call a control total for South West London. But actually no money moves around, and the money is available to be spent in the local areas. So there's no impact in that respect. So we're not going to take money away from one area to another. But what I would say is it's very important for all of us that the whole of the NHS in South West London is in a balanced financial position. People in Kingston access services at St George's. People in Kingston access services as part of a mental health trust across South West London. You know, it's important that all of our services are sustainable. So we want to work together to make sure that that happens, and we make the absolute best of the public money that we receive as an NHS across South West London.
I can do, but for this year moving forward, I can assure you that we have a balanced plan. We are spending our monies on Kingston patients for Kingston. But what we have done, and we've done really quite well, and Naz has made reference to it, we've been quite good at being innovative, and Kingston Coordinating Care and some of the work that we're doing with Kingston Hospital has made our system quite financially sustainable. So I suppose what we need to do is continue to build on the work that we have done in the past and actually spread that good practice across.
Yeah. I wouldn't want to underestimate the pressures that are on current system, though. I mean, Kingston Hospital has financial pressures. Our mental health trust has financial pressures. Let's not underestimate that the NHS as a whole has significant financial pressures, and that it's not easy to maintain the financial balance that we have in Kingston. So, and we will all work very hard to ensure that we do that, but it's not easy.
Any other comments or questions? No? Okay. Please, unless there's any comments from the panel themselves, so please have a little look at the boards around the room and actually have a discussion with ourselves after the meeting. But I'd like to thank you again for coming to the AGM for Kingston CCG, and hope you have a good afternoon. Thank you.